Great, thank you. I'm Michelle Gentile. I'm a radiation oncologist at UPenn. We're going to talk about updates in the management of head and neck cancer, and because that sounds like a big topic, we're just going to focus on viral-induced malignancies. I have no disclosures. So first, we're going to talk about HPV-positive oropharynx carcinoma. Hold it. Okay. We'll talk about the epidemiology worldwide. We'll look at current treatment paradigms, the de-intensification trials in the United States, and future directions. So, around the world, HPV-positive oropharynx cancer is on the rise. Of course, in North America, we have a lot of it, and I would say about 80% of our cases are HPV positive. That may be different in other parts of the world, but the trend is for an increase in HPV-positive tumors. So, we first learned about the good prognosis of HPV-positive tumors from a secondary analysis of the RTOG-0129. And this was a trial that was intended to look at accelerated fractionated chemoradiation versus standard fractionated chemoradiation, which was a negative trial. But what came out of it was analysis of how there was a low risk subgroup of oropharynx tumors. And these patients generally have about a 90 to 95% overall survival. There are other sites in the head and neck region that are HPV mediated, but we don't have a clear sense of their prognosis, and we're certainly not doing anything differently in terms of their treatment. But just to sort of touch on the subject briefly, there was a retrospective NCD analysis that looked at several subsites, including the oral cavity, oropharynx, hypopharynx, and larynx, and found that their 5-year overall survival was higher for HPV positive tumors versus HPV negative tumors. So general treatment paradigm, so for early stage tumors, T1 to T2, N0 to N1, generally we like to remain with a single modality form of treatment, either definitive radiation therapy or hopefully surgery alone. Sometimes there's surprises and we end up recommending adjuvant treatment. Those that are non-T4 have options, so concurrent chemoradiation, radiation alone with altered fractionation if a patient is not a candidate for chemotherapy, or in the case of surgery, often these patients will require some form of adjuvant treatment, either radiation or adjuvant chemoradiation. And then, of course, once you get into the T4, N3 staging, we would generally recommend concurrent chemoradiation. Right now, the standard of care for many centers still, in terms of adjuvant dosing, is 60 gray to the primary site and the node-positive neck, and 54 gray to the elective neck, with optional boosts for ECE or margin positivity. Of course, that depends on each institution's comfortability with dropping doses, and we'll go through some of the recent trials that have been published looking at those lower doses. So in terms of de-escalation strategies, there's a couple of thought processes as to how this can be done. First is induction chemotherapy, followed by a risk stratified treatment approach. And I would say the best example of this is the ECOG 1308, and then surgery followed by lower or no adjuvant treatments. And there's quite a few of these trials that we'll talk about briefly. And then the final category is just lower dose definitive concurrent chemoradiation, HN002, as well as the orator trials. So the ECOG 1308 trial was the first cooperative group to look at lower radiation dose in HPV positive tumors. It took these favorable P16 positive oropharynx patients. They underwent 3 cycles of induction chemotherapy. And then based on their response, if they had a complete response, they underwent dose reduction 54 gray with concurrent cetuximab. If they had less than a CR, then it was full dose radiation therapy with cetuximab. 2-year progression-free survival was 80%, which is a lot lower than what we generally see for these patients. They did find a favorable group on a subgroup analysis, and that included patients that were less than T4, less than N2C, and less than 10-pack-year smoking history. And so, in general, I think many people are not excited about induction chemotherapy. Many would argue that it's not necessarily treatment de-intensification. It's just switching out one treatment for another treatment. The next group is the primary surgical approach. So at Penn, we had our first de-intensification trial that was published a few years ago called the Avoid trial. It was a phase 2 trial. It was single arm. It took about 60 patients with favorable oropharynx tumors. They underwent tours with a neck dissection. And if they had no intermediate features at the primary site, we did not treat that primary site adjuvantly. If they had other reasons for radiation to the neck, including 2 or more lymph nodes or ECE positivity, they, of course, received radiation to ipsilateral or bilateral neck. And they were treated with conventional dosing. The 2-year local control was 98%, so we only saw a single failure for this trial. TORS version 2.0 was just presented at Astro, and so basically it's the next version of what we're doing. Again, it's a phase 2 trial. We had 150 patients. Very similar patients were enrolled as to the Avoid trial. These patients also underwent TORS with a neck dissection. And so, again, we avoided the primary site as per the Avoid trial if they met those inclusion criteria. If a patient required radiation to the high-risk neck, it was reduced dose, so 50 gray. We allowed for additional dose for extracapsular extension. And then the low-risk and contralateral neck received 45 gray and was treated to a lesser volume. And we also allowed medical oncologists to make their own decisions about concurrent chemo. And so if there was less than 1 millimeter of ECE, oftentimes chemotherapy was avoided. Again, excellent outcomes. 2-year local control was 98.8%. So they only had 1 regional failure. There was no local failures. So again, really excellent local control with lower doses and avoiding the primary site. Many may be familiar with the ECOG 3311, which is more of a national trial. These patients also underwent a TORS resection up front, and then if they had intermediate risk factors, that was the group that was randomized to either 50 or 60 gray. 2-year progression-free survival between the 50 or 60 gray was identical, so it was about 95%. And so some people are starting to implement this at different institutions across the United States. We feel comfortable doing it because of our own data as well. The DART trial was a de-intensification trial that came out of Mayo. There was 194 patients. Again, very, very favorable patients. As long as they could have a TORS resection, they were allowed to be on this trial. Cohort A received 30 gray and 1.5 gray BID with docetaxel. So you have to remember this is different chemotherapy and they are giving BID dosing. Cohort B, these are patients who had high-risk features such as ECE, received 36 gray and 1.8 gray BID, again with docetaxel. Their 2-year progression-free survival was great, 96%. They had 0% late grade 3 toxicity with only 1 short-term feeding tube. And something very interesting about this trial was that patients who had pathologic N2 disease, so more than 5 lymph nodes or bilateral disease, and extracapsular extension had very poor 2-year progression-free survival, 43%. And so this is the group of people that you don't want to de-escalate on. Finally, the last category is lower dose definitive concurrent chemoradiation. So HN002 was a trial that was intended to allow for the next experimental arm of our current NRG HN005. So it wasn't meant to be practice changing, but it was patients, again, with favorable HPV positive, less than 10 pack year smoking history, who were randomized to 60 gray over 6 weeks with cisplatin. So basically standard treatment, but 10 gray less, versus 60 gray that was accelerated in 5 weeks. And 2-year progression-free survival favored the concurrent chemoradiation group. And so that was the quote unquote winning group that forms the experimental arm of the current HN005. Orator 2 was meant to be a very interesting trial that many hoped would answer the question for us. It was basically trying to figure out, with all of these de-escalation strategies, which way do we really go? So Arm 1 was essentially HN002, 60 gray with weekly cisplatin. Arm 2 was TORS with reduced dose radiation for the relevant indications. Unfortunately, this trial was closed early given 3 deaths in the TORS and adjuvant arms. So there was some bleeding episodes and an MI episode as well. And so for that reason, we really don't know. Just to touch on HPV positive oligometastatic disease. So we have data for lots of different sites that oligometastatic patients do better. And we have this specifically for head and neck as well. So less than 5 sites associated with improved survival. And these patients really should get tumor-directed therapy in addition to systemic therapy for improved progression-free survival and overall survival. Future directions, there are a lot of de-intensification trials in the United States. I would say the largest category is combining immunotherapy, and there have been some trials that have combined immunotherapy that unfortunately look like they're not panning out very well, but we shall see with the closure and reporting of these trials. At Penn, the next trial that we will have open in the next few months is towards version 3.0, taking the same oropharynx patients and looking at their circulating HPV DNA. As long as it's undetectable post-operatively, they are a candidate for this trial, and they'll get somewhere between 30 and 33 gray in 10 fractions, so 2 weeks worth of radiation. They can have ECE, they can have positive margins. We just escalate the dose to 33 gray. Again, chemotherapy is left up to the discretion of the medical oncologist. We're looking at 2-year local control. And so the integration of this circulating HPV DNA is really an interesting concept that many institutions are really starting to use. Nasopharynx carcinoma. So I know here in Egypt, you're no strangers to nasopharynx carcinoma. It's a little bit rarer in the United States. We'll talk about the epidemiology, the current treatment paradigms, as well as the ongoing trials. And then we'll touch briefly on the side effect profile of treatment for these patients. So again, this is just a worldwide map of epidemiology. As I mentioned, we don't have as much nasopharynx cancer in the United States, but certainly the EBV variant is on the rise. It's endemic to Africa, Southeast Asia, Middle East, as you all are probably well aware. The different subtypes, so keratinizing, that's the WHO type 1. This tends to be patients that are, tumors that are related to alcohol and smoking. And then the non-keratinizing WHO 2 and 3, which are EBV mediated. Basaloid has very poor prognosis. It's rare. It's rarely mentioned in the literature, but something to kind of just briefly say here. And then there are more and more HPV positive nasopharynx tumors that we are seeing. And we think it may reflect from subepithelial extension from the oral pharynx. We don't know a whole lot about the prognosis. There have been a couple of studies in the United States that are, some groups will say that they do better, some groups will say that they do worse, and it's unclear what the treatment paradigm really is for this subset of patients. So going back to guidelines for, any patient with a nasopharynx primary that is N1 or, N1 or T2 N0 or higher, usually we add on the concurrent chemotherapy and some form of adjuvant or neoadjuvant chemotherapy. Just to kind of set the stage for the question of, what is the best approach in terms of the adjuvant or neoadjuvant chemotherapy is the intergroup study. It's a very old study. It is a study that looked at concurrent chemoradiation followed by adjuvant 5-FU with cisplatin versus radiation alone. There was a huge 3-year overall survival and 3-year progression-free survival in the 30 to 40% range. However, compliance for the adjuvant chemotherapy was very poor. It was just over 50%. And so the limitations or the criticisms of this trial was that there were a lot of, there was a high proportion of WHO type 1, which was non-endemic, so we don't know if it could have been applied to other groups around the world. And as a result, we think that the radiation alone group had very poor outcomes. But it left the question, what is most beneficial, adjuvant or concurrent chemotherapy? There have been several small phase 3 trials that looked at radiation alone versus chemoradiation alone with no adjuvant chemo that did show improved progression-free survival and overall survival. Meta-analyses have shown the greatest benefit of concurrent chemotherapy with a 5-year overall survival benefit of about 6%. There was a randomized control trial out of China that tried to answer the adjuvant chemo question. So patients received concurrent chemoradiation plus or minus adjuvant chemotherapy. And in this trial, there was no progression-free survival or overall survival benefit to adjuvant chemo. However, there was a small trend towards it. And so it wasn't felt to be definitive because it wasn't designed as a non-inferiority trial against the standard treatment. And some thoughts as to why this may be is that only 2/3 of patients were able to complete the 3 cycles of adjuvant chemotherapy. Adjuvant chemotherapy may not be as effective on chemorefractory tumor cells that are killed during the chemoradiation therapy backbone. And then there also may be a subset of patients with the highest risk of distant metastases that are most benefiting from the adjuvant chemo. So very practice-changing trial that was published 3 years ago now, comes out of China. Basically, it looked at this concept of giving neoadjuvant induction chemotherapy. They used gemcitabine and cisplatin, which is very active against metastatic or recurrent nasopharyngeal carcinoma. So plus or minus that, followed by concurrent chemoradiation. And there was about a 5% benefit in terms of overall survival for the induction chemo arm. And so for now, many institutions, at least in the United States, that is really what we've adopted. Just to touch briefly on EBV serum biomarkers. So again, we're lucky to have another biomarker here, but it's a valuable tool for monitoring response. PCR detectable EBV DNA is seen in over 95% of nasopharynx patients. It can reflect tumor burden and residual disease. It's associated with stage, recurrence, and survival, and it's very useful for monitoring recurrence. It can predate imaging recurrence by 3 to 7 months. And so there have been studies as to when we should be looking at this value and what is the correct value to be looking at. So really it's the undetectable range at 1 week post chemoradiation therapy. And those that achieve that have a 2-year progression-free survival of 92%. So really, really excellent outcomes. There's an ongoing international trial, HN001, that is using this concept of circulating EBV DNA as a way to decide on adjuvant treatment for patients. So everybody undergoes the concurrent chemoradiation backbone. They undergo a circulating tumor EBV titer 1 week post-treatment. If it's undetectable, these patients are randomized to standard of care cisplatin or 5-FU versus observation alone. If it's detectable, they are randomized to the standard of chemo, cisplatin 5-FU versus gemcitabine and Taxol. So this is currently accruing. It will be very interesting once it reports its data. In terms of the side effect profile, there's a high risk of grade 3 toxicity for the treatment of nasopharyngeal carcinoma. We usually quote about a 10% risk. So we've got all of the classic side effects that we know about for other head and neck patients, but there are some unique side effects. So cognitive decline has been shown to be higher in these patients, both because likely the brain dose, temporal lobe dose is higher, but they're also getting a lot more chemotherapy. Endocrine abnormalities depending on how close your superior field border is to the pituitary gland. Hearing loss is, again, very high risk, both because of all of the cisplatin and how close your volume is to the cochlea. Things like trismus, because of the pterygoids being in the intermediate dose range. Cranial neuropathies from treatment are not unusual. I would say there's a couple of % risk of that happening. And usually those nerves that are at risk are cranial nerves 9 through 12, brain and brainstem injury, and then of course optic injury, again, depending on how large your tumor and sort of how close your intermediate high-risk volume is to your optic structures. I would say one benefit of the induction chemo approach is that a lot of patients really do have excellent responses to induction chemo, and that allows for treatment planning that it eases off a lot of these critical structures. Last thing to mention is proton therapy for nasopharynx carcinoma. So there have been some studies looking at this, and we do think that there is a benefit in terms of oral cavity sparing, maybe some brain dose sparing. We've shown that there's about half of the rate of mucositis and half the rate of requiring PEG tubes during treatment. So, of course, it's something to think about if it is an option for